Hi, welcome back. Now we are starting the third part of our GN series, which is the nephrotic syndromes. Now, for nephrotic syndromes, as we discussed earlier too in the introduction part, they have to be characterized by presence of dysmorphic RBCs. You can also see RBC casts in the urine, which is called glomerular hematuria. Basically, it means that the imagination is that the RBC sort of squeezes out of the glom into the urine, so it sort of forms these blebs on top. I would refer you back to the introduction slides where you can see the slide for this glomerular RBC dysmorphism. The patient can have oliguria and azotemia. They have characteristically very hard to treat hypertension. Proteinuria can be present of variable degree, and occasionally you can see WBCs also. But these are not the defining factors here. The defining factor is an inflammatory process. The entities that we discuss under this are infection-associated glomerulonephritis, which includes post-streptococcal glomerulonephritis, IgA nephropathy, which used to be called Buerger's disease. There are two other patterns of injury, that is MPGN, membranoproliferative GN, and RPGN, that is rapidly progressive glomerulonephritis. This entity just implies that the patient's renal failure is progressing very quickly, and it's a glomerular reason. The three entities under that are notorious for causing this rapid deterioration are having anti-GBM nephritis, or ANCA-associated glomerulonephritis, or lupus nephritis. So let's talk about infection-associated glomerulonephritis. Now, the infection-associated GNs are caused by deposition of immune complexes. It's a type 3 hypersensitivity reaction that the body presents to a past or a present infection. There is activation of classical complement pathway, which happens in pretty much most infections. And it can also happen due to other organisms other than streptococci. That's why we have started moving more and more towards the term infection-associated GN rather than what we used to refer to classically as post-streptococcal GN. In your examination, you can see either of the two terms. You can see it referred to as post-streptococcal, or you can see it as infection-associated. Remember, in the stem, you will have some kind of history of an infection. They might mention some nephrotogenic strains of beta hemolytic streptococci, and there would be a history of an infection, usually 2 to 4 week duration. It's most commonly either the throat, a pharyngitis, or a skin lesion. Now, this is regarding the post-streptococcal GN. Another reason why we keep thinking about it as infection associated is that, in this term, it sort of refers in your mind, you start thinking post-streptococcal. That means it's over, the infection is done. But actually, in quite a few of these cases, the infection is still active, and the pathologist is trying to tell you that you really need to continue to treat the infection in this case, and that is why we have started calling it now more of infection-associated GN. In the kidney biopsy, what you're going to see is something like this. This is called an exudative appearance of a glomerular. And there are a lot of white cells out here. These black nuclei, you can see some of them are bilobed, multilobed. Those are all neutrophils. So an easy way to remember it is whenever you see infection, the neutrophils get activated, and they get activated all over the body. And that's the same case with the glom too. But neutrophils are very active fighters. So when they're fighting this actively, they're sort of almost destroying the whole glom. This is the same picture in different stains. You can see it in the PAS stain, which is very good for defining the basement membranes. You can see it with silver. You can see it in another picture in silver, and this is the trichrome staining. Basically, all that this is showing you is a lot of white blood cells that are in the glom. Now, if I was to get an IF of this, we would see a lot of C3 or complement factor 3 deposition, which is the case in any infection. You see the complement gets activated, and when it's active, it is going to get deposited. Now, EM is a very important part of this post-streptococcal infection. In electron microscopy, you see this is the membrane, this is the basement membrane, and this is the epithelium, and this is this big hump-like deposit. So one way to remember it can be Humpty Dumpty is sitting on this infectious wall. Okay, the wall is very infectious. So the hump-like deposits are an infection-associated or post-streptococcal glomerulonephritis. Now you can pretty much, this picture is pathognomic, so you can expect to see it in different kind of questions. The next entity we are going to talk about is IgA nephropathy. This is characterized by, of course, IgA immune deposits in the glomerular mesangium. This is the most common cause of glomerulonephritis worldwide. If it is only limited to the kidney, we call it as IgA nephropathy. But if it is systemic, that is, the skin can be involved, the respiratory areas can be involved, or GI infections can happen. In all those cases, it can be, we call it as henox-conlin purpura. Okay, it can involve the skin, the intestine, and the joints. It's very important to know because the patient can present with rash, they can present with this pain abdomen, or they can come with arthralgias and joint pains. Now, whenever there is a renal involvement, of course, you're going to see that hematuria. There can be some degree of proteinuria, and we call this synpharyngitic. So, in case of the post-streptococcal infections, you're going to see that stem is going to lead you that the infection was about 2 to 4 weeks old. But if they're trying to lead you towards IgA nephropathy, they're going to say it's ongoing infection. So this is the term that we use for it is called synpharyngitic. These are all areas where IgA is secreted, like it's secreted with a GI infection in the GI mucosa, and that's why it's getting deposited everywhere else also. Here the infection history will be that of days, and it can be accompanied with episodes of hematuria. So the patient might not have consistently hematuria, but they might see gross hematuria today and then not see anything for a few days, and then again they might see it after a few months, something like that. In HSP, again, like we said, it's a systemic disease, and the renal lesion in HSP is similar to IgA nephropathy. It really is the same thing. It's only when it becomes systemic that we call it henox-conlin purpura. The patients can present with palpable purpuras, which are typically involving the legs and the buttocks, and you can see they can sometimes show you some pictures with that typical rash. The mean age of onset is between 6 to 7 years of age, so this is pretty much a very young person's disease. Now this is what it looks like in your biopsy. This is the mesangial area, and this is where there are deposits. Okay, so you can see mesangial proliferation. You can see mesangial here the proliferation is looking worse, and you're going to see multiple different aspects of the way IgA can damage. Remember, again, body's response to infection is always very strong. So you can see pretty much different kinds of involvement in the kidney. You can see segmental scarring with IgA nephropathy. You can see fibrinoid necrosis with IgA nephropathy. You can see a fibrocellular crescent. Here is the crescent. And you can see a cellular crescent. Cellular crescent is just a lot more cells are present compared to the fibrocellular crescent. And these are again areas where we get really terrified whenever we see crescent formation in a kidney biopsy. We need to act quickly for these patients. In IF, because it is IgA nephropathy, the pathologist will tell you that there are mesangial deposits of IgA. And this is what it looks like in the EM. Now, to orient yourself, this is your capillary basement membrane. You can see the podocytes standing on top of those. Yeah. And this is the area between capillaries. So that's your mesangium. And this badness out here, this dark gray stuff, is the mesangial deposit. Now this again, you will not be expected to diagnose based off of a pathology slide. You will get a stem that should lead you towards this. The next entity we are discussing is membranoproliferative GN and dense deposit disease. So MPGN, that's membranoproliferative GN, is just a pattern of injury. Because the membrane is proliferating, you can see it looks like two tracks or two membranes, right? So that's called a tram track appearance. There are two types to it. The first type has some endothelial immune complexes and it's commonly associated with hepatitis B or C infections. The type 2 is called dense deposit disease and it is associated with C3 nephrotic factor. And in a minute it will become clear to you how interesting this entity is. So membranoproliferative, you're seeing proliferation in membrane out here. And these are just different stains that are showing you the same thing, proliferation of membranes. Here in the silver stain, you can see better. If you look at this particular area, you can see it looks like there are two. So it looks like somebody took a pencil and made two membranes. That's the tram track appearance or GBM duplication. You can also sometimes see a hyaline thrombi, but that's not very significant for this case diagnosis. The IF image is going to light up like this, and these are different. The pathologist will tell you C3, IgG, kappa, lambda. They can show you any of this. This is not a diagnosis that IF would give you. In the EM, however, you can see this is the basement membrane. The top of it will be the epithelial lining, and under it is the endothelium. So this is subendothelial intramembranous location. Right out here you can see it just looks like the membrane has become pretty thick in two layers like a sandwich. And there's a lot of deposition in between. This picture is that of dense deposit disease. Now look at how dense this dark ribbon strip is. And this is also intramembranous. Both sides there is a membrane. The podocytes are standing happily over the epithelial side, but this is the endothelial side that you're looking at where this deposit is. So it's right in the middle of the membrane. Now I can understand that if I showed you just this picture, it can be very confusing. But remember, none of these GNs you are going to be asked about just by a picture. You will have a stem to go with it. And the pictures are sort of helpful in saving you time. If you can diagnose something by a picture, then you will know where the stem might be at. But definitely stem is where your diagnosis will be. The next entity is rapidly progressive glomerulonephritis. Remember, so when there is a rapid progression of a disease, it carries a very poor prognosis. We have three entities under this. The anti-GBM, antibody-mediated crescentic glomerulonephritis. This is a type 2 hypersensitivity reaction where there are antibodies to GBM. There are same antibodies also react against the alveolar lining. So these patients can present with hemoptysis along with hematuria. This is a constellation of pulmonary renal syndromes. So you see hematuria and hemoptysis, and these are treated pretty emergently with plasmapheresis. We are trying to take out all these antibodies as quickly as possible. The next entity is posse-immune crescentic glomerulonephritis. This can be of two types, the PR3C ANCA, which used to be called vaginous granulomatosis, or the MPO or P ANCA, or microscopic polyangiitis. My personal mnemonic for this is you see Uncle Wegener to do a per rectal exam. Now, please keep it to yourself. It helps me remember PR3C ANCA is a vaginous granulomatosis, and the other one is MPO or P ANCA, which is microscopic polyangiitis. Okay. The third variety is immune complex mediated crescentic GN. Now IF is pretty diagnostic in this entity where you can see this linear IgG deposition in anti-GBM nephritis. The pathologist will tell you that this is an IgG. In the regular stains, what you still see are these crescents which are eating up the gloms. Again, different stains, but the glom is pretty much being destroyed by these crescents. Now in ANCA-associated glomerulonephritis, you're also going to see pretty much very similar picture in the regular stains. You know, they can be fibrinoid necrosis, but same thing as cellular crescent. Same thing, like crescent is eating up the whole glom. But here the IF picture is very different and you're just seeing some mild lighting up. That's why it's called posse immune. It's not no immune, otherwise it would have been completely black. Now, ANCA vasculitis is a big part of the ANCA-associated GN. Vasculitis means blood vessels have to be involved. And as you can see, there is necrotizing arteritis. This is an artery which has a necrosis going on here. And this is the same thing being shown by different stains. Basically, in this picture, you can see this is the normal side of an artery and this is the destroyed side of the artery where the necrosis has happened. In immune complex mediated crescentic GN, our prototype baby is lupus nephritis. Now, lupus nephritis can present in any of these classes. Class 1 has minimal mesangial lupus. So you're going to see pretty much minimal changes. Class 2 lupus nephritis, you're going to see something in the mesangium. So mesangium will proliferate. Class 3, you will see some focal or less than 50% of glomerular involvements with active disease. In class 4, you can see diffuse. Remember, this was a term for more than 50% of glomerulus being involved. Class 5 is entirely different with a membranous-like picture, so it's membranous lupus. And class 6 pretty much means that the whole kidney is getting sclerosed and there is nothing much to salvage as far as lupus nephritis is concerned. You will still treat the patient for lupus because lupus will be affecting the patient's other organs, but your kidney is pretty much done for. Now I want you to remember the different entities you've already studied. Minimal mesangial lupus will look very much like minimal change disease. Mesangial proliferative lupus can look very much like IgA. Focal and diffuse will look like very active lesions. They'll have a lot of cellular stuff going on and they're also treated very similarly. Membranous lupus will look like membranous GN that you've studied before, and sclerosing lupus will look like end-stage kidney. So a normal glomerulus, which would be like stage 1, the patient must carry the diagnosis of lupus to start with. You cannot say that this patient has lupus nephritis unless the patient actually has lupus. Otherwise, based off of this, I would have called it minimal change. Now here you see there is mesangium that's looking little more than it should be. So that's mesangial proliferation. You can see crescents in the proliferative lupus. This can be class 3 and class 4. Okay. And you can sometimes see hyaline thrombi also. Now wire loop deposits are very classically described in lupus. You can see a crescent here. And this is very much like the membranous GBM spikes and vacuoles that you've seen before in membranous glomerulonephritis. If the patient carries a diagnosis of lupus along with that, we will call it class 5 lupus nephritis. The reason why these differences are made is because it affects the way you're going to treat the patient. In lupus class 6, you can see that each of these gloms look kind of dead and gone. They're just looking like small blobs out there. And for renal pathology stains, blue is bad. The more blue you see, the worse it is. So this is pretty much all sclerosed kidney. In this patient, I would not do any immunosuppression to try and salvage any of that kidney. Okay. In IF, typically, the pathologist will report to you that there is a full house staining. So pretty much every stain that they know about will light up. You can also see some tubulointerstitial deposits. So basically for lupus, my way of remembering it is that lupus largely affects pretty much everything in the kidney tissue. And you can see any of these patterns. In EM, you can see deposits which can be in the mesangium or they can be present subendothelially. This is the endothelial. Again, orient yourself. Here is the basement membrane. The podocytes are standing on top of it, and the endothelium will be inside. So these are subendothelial deposits, and you can see deposits like this, which you have seen in membranous, and this is a subepithelial deposit. Okay, so this is under the epithelium. Now some of you may have a question that isn't this what infection associated looks like? Yes, it can, but remember, in infectious associated is also subepithelial, but that's a big hump. So the Humpty Dumpty was sitting on the wall with an infection. Here there are multiple different electron deposits, and they are pretty much same sized. One of the entities that I want to talk about is hereditary nephritis, and for the question they have to give you some kind of a genetic background. It's usually X-linked, involving mutations in genes that code for type 4 collagen in GPM. Typically, the patient will present with microscopic hematuria, mild proteinuria, and hearing loss. And they'll have several family members that will have the same history. Some patients can also have eye abnormalities like retinopathy and anterior lenticonus. They can have sensorineuronal hearing loss, and rarely they can have leiomyomatosis also. This is what the EM is going to look like. We went straight to the EM because that's where the defining picture is. This is known as basket weave appearance. Okay, so this is, the basement membrane has become all disrupted. Again, you will not be expected to diagnose this entity based off of the EM. They will give you a full-fledged history that will have what I mentioned just before this. There is one more entity which closely resembles Alport's, and that is thin basement membrane disease. This is called benign familial hematuria. It's called benign because it has pretty good prognosis. Here, the basement membrane is basically very thin, that's all. Because it's thin, the patient can have asymptomatic hematuria, which is incidentally found. Typically, the history can say that there was this patient who went for a wellness exam and was found to have hematuria, and then he will report that, yeah, it had been mentioned in my high school also, and pretty much some of my family members have the same thing, but there's no history of progression of the kidney disease. And good part is that okay, so I am a Boingo online success. Omit that, I'm not going to retape this. Now this is what the EM is going to look like. This is just a very thin basement membrane, but it's not disrupted like that Alport's one was. Okay, it's pretty decent looking thing. Okay, and that brings us to the end of our glomerular nephritis section. I hope you'll be ready for some questions in the class. Now write to me. I'll be happy to answer any questions. You can email me. And I hope you enjoy GNs as much as I do.